Coming to lovely Chicago for not only ASCO, but I really appreciate you all coming to the SARC meeting. Obviously, there are a lot of folks to thank, and I'll get to that in a moment. But in the meantime, there's on your tables are the program agenda with a QR code in the upper right. We'd request throughout the meeting if you could sort of rate some of the sessions and give us feedback on what you're thinking about the various sections. With that in mind, we're running late, so I'll just jump right in. SARC, by definition, is made up of many, many, many volunteers and collaborators, so investigators, patient advocates, survivors, all the above, our pharma partners. And I'm not going to go through this in detail, but I'm just showing almost everybody on these slides are volunteers that have been working with SARC today and for many years as we go forward. First, we have our board of directors, not surprisingly, our scientific steering committee, which is our executive scientific committee. Then we have our Discovery Translation Committee, which is really focusing on a relatively new part of SARC, which I call SARC Science. I'm not a scientist, so that's why I call it. Jonathan Fletcher leads that group. We have the Clinical Trials Development Committee, which, if you will, is, I won't go through who's on it. It's an intramural trial development tool. And so if you have ideas for a study, we can cultivate it. They can work with you to help fine-tune, or I'll use Scott Acuno's term, polish up the concepts, and then we move them forward, hopefully through the translational method of SARC. We also have a multidisciplinary tumor board, and Dr. Acuno will reference that later. We also have a brand new program which we launched last year called the Sarcoma Centers Directory. Dr. Chappie Conrad will discuss that later. We have a steering committee made up of several of your clinical colleagues that work with Dr. Conrad et al. To help focus this new and exciting patient-facing tool. So I have to go back one. We also have, well, this is just a slide. It stopped moving. There we go. This is just an overview. For the sake of time, I'm going to skip over it. Dr. Acuno will go through it. Dr. Conrad. Research Advocacy Council, this is a group that was established under my predecessor, Denise Renke, which really gets the patient's voice embedded into our clinical trials. And we're continuing to grow and expand that group and do a better job at interdigitating them into our programs. Then lastly, and critically, I have to thank the SARC staff. This meeting would not have been possible without them, and I want to particularly call out Claudia Hill, SARC's Chief Operating Officer, and Kim Ward, the title doesn't do her justice, the administrative associate for the organization. We could not have done this meeting without them. And then in closing, I just want to thank our sponsors. Adi Biosciences that really stepped up as the top supporter. Ratio Therapeutics, as well as Decipherer. We keep going over how to pronounce that. Immunocore, Ipsen, Parabolis Medicines, and SpringWorks Therapeutics. So thank you to all our sponsors, which made this meeting possible. And then also in terms of thanks, Dr. Pollack, this meeting, please come on up. This meeting could not have been possible without the collaboration of Northwestern, incredible group of people, and I think it's so wonderful to hold the meeting in an major academic center and a major sarcoma program.
Yeah, I just want to say thank you so much for coming. It's such a privilege to host SARC. SARC has been such an amazing part of my career. It's, I couldn't be where I am today without the SARC Career Development Award that I got many years ago, and we've had so many important SARC trials that have come over the years, and I love the SARC meeting, and it's just such a privilege for us to host. Because I have this opportunity, I want to just show off our institution just a little bit. I want to introduce Pedro Viveiros, who is my partner here at Northwestern, and he is fantastic. We actually just hired another medical oncologist who's going to join us here. We're happy our institution is growing. That green field that you may have walked by on your way here is going to be a new cancer hospital that's going to be part of all this. So, we're really happy to be able to host and show off our fantastic institution. So thank you so much.
So welcome. My name is Scott Okuno. I'm a medical officer, chief medical officer for SARC. I'm a medical oncologist at Mayo Clinic, and it's a great privilege to be here today at Northwestern. And Seth, thank you, and thank you for the people that made this possible. We just wanted a quick highlight because I know we have 4 components today, and we want to get to those. But SARC is really involved with clinical trials, and you hear more about today on the clinical trials aspect. We also want to connect with all of you between our meeting here at ASCO SARC as well as CTOS. So over the time, we've developed a SARC tumor board. We've also have a podcast, a monthly podcast. We also have a clinical trialist forum that allows us to engage with all of you with the active clinical trials that are open as well as in development. So if you are interested, please let us know. Our next one is on July 15th. Jonathan Fletcher is not here today. He's our Chief Scientific Officer, and he'd be remiss if we didn't share with you our SAS meeting, which is on October 14th through the 16th this fall. And Dr. Wiedemann, Dr. Singer, and Dr. Fletcher are pulling this together. We do realize that this is technically a small knit group, and we're always constantly balancing who can come, who should be there, so we're just refining it as we go along. And there's a lot of excitement of what we're planning for 2025 at SARC CTOS, so we look forward to everybody being there as well. If you are interested in submitting our monthly cases to our tumor board, Gina D'Amato leads this group here. On our website, you can see there, and there's a click button there, submit your cases. We typically have it on the 2nd Friday of every month. Yes, this is Central Time, which may or may not appease everybody in the room, but that's what we've landed on. We also began SARC Talk, which is a podcast, and we've interviewed many of you, so I appreciate your time, and we look forward to future podcasts as well. We're currently in our 3rd season. We've done 31 to date so far, and it was really allowing us to continue to share our message of what sarcoma is, maybe not to this audience, but people outside, because awareness of sarcoma is going to be really important as we continue to move forward. If you are interested in knowing about the podcast, we have a Spotify, Apple Podcasts, YouTube, and website, so you can sit there and listen, and I always say, put it on 2 or 3 times speed so you can listen to it quickly, so just to let you know. So if you have any questions about SARC or what we're doing, these are the people here, myself, Stephen Young, as well as Jonathan Fletcher. So with that, we will migrate and move to our first session today, and this is led by Dr. Sandra D'Angelo, and we'll let her introduce the next topics. Thank you.
Thanks so much and welcome. I'd just like to start by highlighting that Dr. Kalbasi couldn't be here today, so I'm here stepping in. This session was his vision, and I'm here just to step in and moderate in his absence. And so the topic today that we'd like to discuss is the results of SARC 032. This was a pivotal trial that evaluated the role of neoadjuvant checkpoint blockade for UPS, Myxofibrosarcoma, and undifferentiated liposarcoma. The question that we now have is this a new standard of care, and how will we implement this in our current clinical practice? I'd like to start with a question and have the audience participate. If we can bring up the question, please. So is neoadjuvant immunotherapy a standard of care approach for patients with large, high-grade, primary localized extremity trunk soft tissue sarcomas? Those are the 4 choices. Please answer the question. We'll highlight the answers, and then we'll bring up our first speaker. Okay, so here we are. Seems that there is some back and forth and people still polling, but let's stop right now, and we need to move on. We're running late. I'm going to have Dr. Rydell join us and start with just an overview of the trial and the data.
Good morning, everybody. Welcome to SARC. It's nice to see a number of friendly and familiar faces. I fully recognize that I am not the main event, and I'd argue I'm probably not a worthy undercard. And I'm pretty sure that I wasn't the first choice to give this talk. But here we are. Here we are. So we're going to run through this. We're going to take about 10 minutes and just review SARC032. All right, so the hypothesis is shown here. The hypothesis was that the addition of neoadjuvant and adjuvant pembrolizumab to surgery and radiation therapy for localized soft tissue sarcomas will improve disease-free survival. And this was based on preclinical data showing synergy with radiation and checkpoint inhibition, but also really seminal work that was published by Hussein Talwi back in 2017, and then an update by Missy Burgess in 2019 showing that the use of pembrolizumab for patients with advanced disease had encouraging results. In the initial study, response rates for UPS were around 40%, and 20% for liposarcoma, but with the expansion cohorts a bit more modest, but still some potential signals. So the primary objective for 032 was to look at disease-free survival. The secondary endpoints and exploratory endpoints are shown, including looking at recurrence-free survival, overall survival, and a number of associated correlatives. And the study design is shown here. Patients with stage 3 disease, tumors greater than 5 centimeters, grade 2 or 3, limited to UPS or liposarcoma, were randomized in a 1-to-1 fashion to either standard of care, which was preoperative radiation therapy to 50 gray, followed by surgical resection, or to the experimental arm, which consisted of neoadjuvant pembrolizumab, a dose before, during, and after radiation therapy, followed by surgery, and then adjuvant therapy to complete a total of 1 year. I briefly mentioned the correlatives. Tissue and blood was collected. We've heard about some of these results from Everett Moding back at CTOS, and probably more to come over the coming years. The eligibility is shown here. Patients older than 12 were eligible. Again, stage 3 disease, greater than 5 centimeters, intermediate to high grade, and limited here to UPS or the mentioned liposarcomas. We were looking for 126 evaluable patients. The power statistic is shown here. We were looking for an improvement in disease-free survival at 2 years from 50% to 72% in the experimental arm. This was an international effort, 15 sites with about 60% of patients enrolled in the US, about a third of patients actually enrolled in Australia, and you can see that it took quite some time to accrue in the middle of COVID, but we got it done. So here are some of the patient characteristics. This is for the evaluable patients, equal representation with sex, age, grade, and then with respect to histology, the vast majority of patients enrolled had UPS. Shown here is the primary endpoint. This is the modified intent to treat analysis based on the evaluable patients, showing an improvement in disease-free survival with an estimated 2-year disease-free survival for the experimental arm at 67%, compared to 52% for the control. When you look at the entire number of enrolled patients, the intent to treat, similar results were seen. When we looked at post hoc subgroup analyses that were underpowered, we saw that much of the benefit appeared to be for individuals with grade 3 disease as opposed to grade 2. And when we looked at histology based on the resected specimens, there were separations of the curves for both, but neither reached statistical significance. With respect to secondary endpoints shown here, separation of the curve for distant disease-free survival, but did not meet statistical significance, and no obvious meaningful difference for local relapse-free survival. Overall survival premature here and will be followed, but no difference. And then with respect to safety, not surprisingly, there were more grade 3-4 events for individuals who received pembrolizumab. There were no new safety signals, and importantly, there were no increase in major surgical complications in the experimental arm. So based on the results, the addition of pembrolizumab in combination with radiation and surgery improves disease-free survival. The highest benefit appeared to be individuals with grade 3 disease, no significant difference in the other outcomes that were assessed currently. Correlatives are ongoing, and SARC032 has established the use of pembrolizumab as a potential option for patients with stage 3 UPS and liposarcoma. I'll just highlight the acknowledgments here. Before we get to the main event, I do just want to highlight the words from the famous ring announcer Michael Buffer as we get ready for this debate.
Let's get ready to rumble!
Thank you.
So Dr. Bui, please join us and share your perspective with regards to why this is a new standard of care.
I'm pressing the green button. There we go. Okay. So I have the lead, so I better not lose it. But so I will be the proponent in this debate of neoadjuvant immune checkpoint blockade for UPS, Myxofibrosarcoma, and D. diff lipo. Is this the new standard of care? So this is the age-old debate for a new era. In many meetings past, we always used to debate whether chemotherapy was superior to no chemotherapy for adjuvant therapy. And despite all the debates, I'm not sure if we ever came to a consensus because everybody still does different things depending on how they interpret the data. So I think now it's time to bring this to the new era for immunotherapy. I also would like to mention that coming from the Bay Area, right in the middle of Silicon Valley, I've learned that the more you use the word AI or artificial intelligence in your talk, the more exciting it is and the more funding you get. So I want to say that I use AI to basically just generate funny clip art for this presentation. So this is SARC032, as Dr. Wydell explained. Here's a schema of the cartoon where the primary disease-free survival was a 2-year disease-free benefit of 22% at 2 years. And here's the primary outcome. It was a positive trial with a hazard ratio of 0.61, so a 49% improvement in recurrence with an absolute benefit of 15% at 2 years. If you look at some of the secondary outcomes, you can see that it was driven a lot by a decrease in distant metastases with a hazard ratio of 0.62, but no change in local recurrence risk, and an overall survival, which was immature. There was a trend towards improvement, but it was not significant. There was a low number of deaths at about 3 years. About 75 to 80% of patients were still alive in both arms. So mission accomplished. We have a positive trial that is statistically significant and clinically meaningful. And so based on this data, we should recommend it for all the patients who are in the inclusion criteria. But I think we need to take a step back and say, is this actually the way we should approach it for all patients, or is there some nuance? So I want to go back a little bit and think about why we do neoadjuvant therapy. So the goal of adjuvant systemic therapy is to treat micrometastatic disease and decrease the risk of recurrence after surgery and therefore improve patient survival. And back in the chemotherapy days, if you are a proponent of giving chemotherapy adjuvantly, you would cite the SMAC meta-analysis in 2008, which showed that combination of doxorubicin plus ifosfamide improved outcomes in survival over doxorubicin alone or with no chemo, with a relative risk of 0.56, leading to an absolute risk reduction of 11%. If you're on the other side of the debate, you would say that we've run multiple randomized controlled trials which have shown no benefit, including the EORTC 62931 trial, showing no difference in OS or RFS. And they recruited 351 patients with a hazard ratio that was pretty much 1. All the curves overlap here with an absolute difference of only 1% at 5 years, which is well within the margin of error. But when you look at the subgroup analyses, you start to see some interesting trends that maybe some patients benefit more than others. As you can see here, tumor size more than 10, as well as grade 3, seem to benefit more from adjuvant chemo. And this is the idea that not everybody benefits equally from adjuvant chemotherapy. And so this is where we should look into risk stratification, so the right treatment for the right patient, trying to divide between low, medium, and high risk and only treat the high-risk patients. So what do we have so far for chemotherapy in sarcoma? Well, we have a clinical nomogram called Sarculator, which has been developed and validated specifically for risk stratification in extremity and retroperitoneal sarcomas. And you can download it on your phone right now, and you can basically plug in age, tumor size, grade, and histology, and it gives you the overall survival and the distant metastasis rate at 5 and 10 years. And this has been validated across different data to show that an overall survival at the cutoff of 60% can predict a benefit from adjuvant chemo as well as be prognostic for disease-free survival. So here it is applied to the histology-specific adjuvant trial, showing that at the cutoff of 60%, those with higher risk do much worse than those with lower risk. And it's also predictive for improvement in overall survival with AIM chemotherapy, with the high-risk patients improving their outcomes with AIM, while low risk, there's no improvement with the more intensive chemo versus the histology-specific, because their prognosis was very good with overall survival around 80% at 5 years. But I wanted to take a little bit of a deeper dive into Sarculator because we use it now for chemotherapy stratification for adjuvant, but what are the operating characteristics in relation to what we use for SARC032? And so what I did was I basically went into my phone and plugged in all different combinations of grade, tumor size, histology, and age across UPS, MFS, and DDLPS to create these operating characteristic curves for Sarculator. And the way to interpret it is on the y-axis you have the prognosis going from 50 to 85%, and on the x-axis you have tumor size. So the way to look at it is when the curve intersects at 60% for high risk, the tumor size that you get is what you would say you would need chemo because you're high risk. And you can see that for grade 3 for Sarculator, you would need actually an 11 centimeter grade 3 tumor to be high risk and qualify to benefit from adjuvant chemo. Whereas for lower risk for grade 2, that will actually never intersect the 60% cutoff, even up to 15 centimeters. And this varies based on histology, so Myxofibrosarcoma is higher risk, so you need a lower tumor size at 10 centimeters, UPS is 13 centimeters, and differs by age, so 30-year-old patients are at low risk, so a 15 centimeters cutoff, whereas a 70-year-old only needs an 8 centimeter tumor. And it's very important to realize that this differs from the SARC032 inclusion criteria, where high-risk adjuvant treatment was defined by tumor size more than 5 centimeters and included grade 2 and grade 3. So how do we harmonize these different approaches to whether we give adjuvant chemotherapy or adjuvant immunotherapy to the same patient population? And this boils down to the fundamental question of how do we choose high-risk patients? So I think that's one important nuance to think about when we think about applying SARC032 in terms of adjuvant therapy to our patient population. What about the risks of neoadjuvant immunotherapy? So switching gears here. So the main concern is potential for progression and the tumor becomes unresectable or becomes metastatic during your neoadjuvant treatment course. Fortunately, in SARC032, no patients had canceled surgery, and I think this was because of concurrent radiation minimizing the risk of primary disease progression. I do want to caution that this is a related trial in a different cancer, in non-small cell lung cancer, where they did a neoadjuvant immunotherapy only arm, so no radiation, and compared it against chemo. They actually had a very characteristic inverted event-free survival curve, where the immunotherapy only arm had higher rates of progression, leading to higher rates of canceled surgery, almost double the amount, 16% versus 8%. Although you can see in the tail end, those patients who remained on immunotherapy did much better than chemotherapy. So this is a word of caution that we may have some increased rates of distant mets for patients who may not be as responsive to immunotherapy, as we can see in the non-small cell lung cancer trial. What about toxicity? In my opinion, I think immunotherapy is much less toxic than chemotherapy, especially AIM chemotherapy, which is a standard of care for adjuvant chemotherapy in sarcoma. There's no risks of neutropenic fever and severe sepsis. There's much less nausea and fatigue, and patients tend to have much better quality of life. They can still continue to work and do their ADLs without much impact. However, I will say that having treated a lot of patients with immunotherapy, the toxicities are very idiosyncratic and not as deterministic as chemotherapy. And what I mean by that is that not all patients will get the same side effects. Some or most will get zero toxicity and do fine, but a few will get severe toxicity. And I think a really important, another key point is that immune therapy toxicities can require immunosuppressants and last long beyond the time period of active systemic therapy. You can get pneumonitis, you can get type 1 diabetes, you can get thyroid dysfunction that still lasts beyond the time that you are actually on active systemic therapy. Whereas with chemotherapy, for the most part, the adverse events such as cytopenias requiring transfusions, neutropenic fever, and sepsis generally are confined to the time period of active systemic therapy. So to illustrate this is actually one of the patients I treated, an elderly lady with massive hepatic angiosarcoma, 89-year-old female, diagnosed 4.5 years ago with multifocal hepatic angiosarcoma, the largest lesion being 9 centimeters. She did not tolerate paclitaxel or pazopanib, so we started her on ipi-nivo immunotherapy about 4 years ago. And if you look at the efficacy, there was amazing efficacy, complete response of the splenic lesions, significant improvement in all of her liver lesions. And this is a scan from 4 years later, so she is still in a very good remission and having very good quality of life. But if you look at her lungs, this is not cancer. This is all pneumonitis, and this is still 4 years later. So she actually has had symptomatic pneumonitis for the past 4 years, even after discontinuing nivolumab after just 1 year of treatment. And she's been treated intermittently with courses of prednisone and tocilizumab. And she still has ongoing pneumonitis 3 years later, having to continue to see pulmonary and with occasional ER visits for shortness of breath. But she still continues to have great disease response and still has not required further treatment for her angiosarcoma after 3 years off therapy. So I think this is kind of the balance we seek, with adjuvant therapy is if you're going to subject patients to something, are you going to get them to trouble many years later that you still have to handle? So how do I decide between adjuvant chemotherapy versus immunotherapy? So I think, one, for histology, I think only the subtypes in SARC032 should be considered for adjuvant immunotherapy. Chemotherapy-sensitive subtypes such as synovial and myxoid round cell should receive chemo. I think for location, SARC032 is only for extremity tumors, so it does not apply to retroperitoneal or other locations. Comorbidities, so age over 65, cardiac history, so a low EF or a lower performance status, may be too toxic to get chemotherapy, so you should consider them for immune therapy. Patient preferences. Patients may feel strongly to avoid chemo. I rarely encounter a patient who wants to avoid immunotherapy. Risk stratification. So as we went into earlier, the risk score for adjuvant immunotherapy, 5 centimeters, grade 2 and grade 3, is lower and more permissive than the circulator 60% cutoff. So for intermediate patients, maybe we should consider immunotherapy. And then finally, the need for urgent cytoreduction. For borderline unresectable or rapidly progressive tumors, AIM chemotherapy seems to have higher response rates and less risk of progression, so you may want to consider that. And what about the future? So I think although we just treat sarcomas, it's important to look at all the other cancer types because they may give a hint of what's to come. And I looked across different cancer types, including very common ones such as lung, triple-negative, bladder, and head and neck. And those have all been tumors which have standard of care adjuvant chemo for decades with cisplatin, ACT, GEM-CIS. And you can see that in the past 5 years, all of them have added adjuvant PD-1 on top of chemo as a standard of care. And this has all been approved within the past 5 years. You can see the column on the right. And the hazard ratio for all these trials have been around 0.7 to 0.8, with the absolute 5-year overall survival benefit around 5 to 7%. So this may be the direction that we're headed. So finally, my conclusions, I do think that with a positive endpoint in SARC032, that checkpoint immune therapy is effective to reduce recurrences in UPS, MFS, and LPS, especially with distant metastases. I think patients meeting SARC032 trial criteria should be offered pembrolizumab neoadjuvant therapy, but do we really know who is high risk? And chemotherapy with doxorubicin can also be offered to high-risk patients, and this would be with AIM chemotherapy. And finally, as of course to hedge, individual patient factors and their own personal decision-making is the key to decide between neoadjuvant immunotherapy versus chemotherapy. And that will be my first talk.
Dr. Mia?
Good morning, everyone. Thank you so much for the invitation. I'm a clinical oncologist at the Royal Marsden Hospital, and so in my job I deliver systemic treatments alongside radiotherapy when we do offer systemic therapy in localized disease. I have no conflicts of interest to declare, but I do have a confession. I saw David at CTOS last year, and I did fangirl him, saying what an amazing study this was, and a great study, great presentation at CTOS on the translational research, and I think this is a practice-changing study. And now I stand here 6 months later arguing against this. So hopefully the scope of my study and my discussion will involve these aspects in arguing against Nam. And I think congratulate Nam for an excellent summary of the data and his presentation. So we know that tumors with high mutational tumor burden have an increased level of neoantigens and higher immunogenicity. But in sarcoma, as we're all aware, it's a heterogeneous group of diseases, and there's significant variability in TMB among all these different histological subtypes. And as being described earlier, SARC28 highlighted that there are certain subtypes where immunotherapy may be of advantage, particularly UPS and LPS. Importantly, looking at the translational research performed alongside this, this has highlighted another way of classifying these histological subtypes according to sarcoma immune class groups, and showing that hot tumor groups D and E, particularly E, associated with improved survival and anti-PD-1 therapy response. And I think this is really important to highlight, and I will go back to this later in my presentation. What you can see on the waterfall plot on the left is, despite the different histological subtypes, even within those histological subtypes, there's variation regarding which group of sarcoma immune class they sit in. So are all DD, LPS, and UPSs the same? So looking at immunotherapy, we know that there is data to support that neoadjuvant and adjuvant is superior to adjuvant treatment, as seen in the melanoma studies. It improved event-free survival in those patients and increased pathological complete response. In addition, we also know that doublet, so I know we're talking single agent at the moment, but doublet potentially could offer enhanced efficacy, but at the expense of increased toxicity. So need to be mindful regarding considering as a combination. My colleagues at MD Anderson looked at how radiotherapy can affect the the tumor microenvironment. And what we do know from the literature that radiotherapy can act synergistically with immune checkpoint blockade to improve local and distant tumor response. In this study, 17 patients' tissues pre- and post-treatment were evaluated. And in summary, it suggested that radiotherapy may be changing the tumor microenvironment and potentially enhance the efficacies of immunotherapies, particularly in UPS in this study. My colleagues went on further to perform a randomized study of a non-comparative phase 2 of neoadjuvant immune checkpoint blockade in combination and then concurrent radiotherapy with nivolumab, both in the dedifferentiated liposarcoma group and the UPS, and showing significant efficacy in the UPS group. So there's the background data to present this study, which has been described quite clearly already. This is an excellent design study, and again, do congratulate everyone who participated. We know the most important part of why we're doing this is our main unmet need, that we need to avoid metastases because that impacts on overall survival for our patients. And so, of course, to test this hypothesis, this needs to be done in a randomized phase 2 study, and completely understand that. And what is encouraging, this was a multi-center international study, but what's worrying in this common subtype, only 143 patients were recruited over 6 years. I think the most important part of the study is the translational aspect, because we learn more from this as to how we go forward. So, now beginning to critique the study. So yes, the primary endpoint was powered to detect a 22% difference in disease-free survival. Of course, standard secondary endpoints were determined and looking at the differences, but not powered for that. There was a pre-specified subgroup analysis of disease-free survival based on tumor grade. So patients were stratified according to grade prior to randomization. And of course, as we've described already, post-hoc subgroup analysis of overall survival based on grade and disease-free survival based on histology were undertaken. But if you look at the histological subtypes in more detail, you're approaching 80% had UPS, 6% in each arm for dedifferentiated liposarcoma. And look at the pleomorphic liposarcoma. There's no patient in the pleomorphic liposarcoma group which actually received the experimental treatment. So I don't think we can actually conclude on this subgroup regarding efficacy. Now we look at the primary endpoint. Yes, there has been an improvement in disease-free survival, but I stress this is estimated disease-free survival. And when you look into that in a bit more detail, and looking at the fine print in the manuscript, you see that 2/3 of patients have potentially completed 2 years follow-up. And actually, more detail noted that the median number of cycles of pembrolizumab patients received were 14, and obviously the maximum number is 17. But if you look at the interquartile range, there were patients who received only 5 cycles, and that translates to receiving 2 cycles post-operatively. And as I've highlighted already, the subgroup analysis, no differences in disease-free survival according to grade or histological subtype. And as expected, no significant improvement in overall survival. So the conclusions to draw from the clinical and translational analysis of the SARC032 is that pembrolizumab added to pre-op radiotherapy and followed by surgery does improve survival in stage 3 UPS. The highest benefit is seen in the grade 3 patients, but underpowered in this analysis. Yes, we know, and it's been addressed, that pembrolizumab can increase adverse events, but also of note, no increased wound complication, which is reassuring. And looking through the publication, there was no delay in patients proceeding to surgery. So commonly, patients were not deconditioned. Looking at this translational analysis, which is similar to what was described in SARC028, is there's a quarter of patients who were analyzed to be in the sarcoma immune class group E, and suggested those patients had an improved disease-free survival and could be considered as a prognostic factor for DFS. Unfortunately, the study was underpowered to determine if this subgroup is a predictive marker for response. So where does this sit in the treatment landscape of localized soft tissue sarcomas? And I apologize for this very busy slide, but just trying to summarize what we do and don't know about chemotherapy. Nam kindly went through all the data sets, but if we go back to the two meta-analyses, obviously initially there was no improvement in overall survival in the 1997 SMAC analysis, and then when further additional 4 new trials were added to the updated analysis, there was an improved overall survival benefit. But if you look on the top row in the European experiences, obviously we've had adjuvant chemo versus surveillance improving survival, 3 neoadjuvant plus 2 adjuvant versus 3 neoadjuvant was demonstrated equivalence. The EURTC study demonstrated no improvement in overall survival, but this was further analyzed, adding in Circulator in 2019, suggested that the poor outcome cohort benefited from chemo. Also, we haven't even described regional hypothermia showing an advantage in improving overall survival with doxyphos compared to surveillance. And then most recently, I think the last study is describing the neoadjuvant anthracycline ifosfamide-based chemotherapy superior to histologically driven schedules. So I think the questions are still unanswered regarding the role of chemotherapy, neoadjuvant or adjuvant. How many cycles should we be given? Who should receive chemo? Who should receive immunotherapy? I'm just asking you lots more questions. I'm not giving you answers. I'm sorry. So comparing the last neoadjuvant study that looking at standard chemo versus histologically driven, if we focus on the disease-free survival data, we can see that that's approaching about 60% in the inferior arm and above 70% in the standard chemotherapy arm on disease-free survival. Now, when we compare that to the SARC032 study, we see that the control arm is inferior to what's been described, highlighting, are we under-treating some of these patients already? And is this a true, have we truly got the correct control rate for these patients? Of course, in both, also we note that there's been no overall survival benefit in the SARC032 as expected, and also we note that the overall survival is inferior to what's been described in the last neoadjuvant chemo study. But also mindful within this neoadjuvant chemotherapy study, you had 5 histological subtypes. We know UPS has a poorer prognosis, so mindful if that's part of the reasons why. And additional analysis to take into consideration, my colleague Dr. Shani Zaidi highlighted this paper to me, an excellent paper, and congratulations to all the authors. This looked at an improved definition of a molecular landscape of soft tissue sarcomas. And what it highlighted is that inferior survival was seen in immune deplete cluster tumors compared to immune enriched tumors. And further to this, what was determined from this cohort was that with differential expression analysis, the cold tumors had more upregulation of genes related to tumor proliferation. So does this, in my simple mind, suggest that chemotherapy may be more beneficial in those patients, or in certain subtypes, can RT improve the efficacy of immunotherapy in selected cases? And when you look at the hot tumors, the upregulation of immune-relevant genes perhaps gives you more confidence to use immunotherapy. This is just 2 examples of UPSs that were treated in the last 5 years. So the patient on the left is an undifferentiated pleomorphic sarcoma who received neoadjuvant chemotherapy, had an excellent response, then had radiation and surgery, and well to this day. More recently, this gentleman had an inoperable tumor at UPS, and that's after 2 cycles of doxyphos chemotherapy and no response. So we know that the disease histological subtype isn't the whole story. And then we go on to the lovely, nice technology appraisal that we love in within the NHS. So we look at cost-utility analysis, which measures quality and quantity of life, and measured as a quality-adjusted life years. And we can determine an incremental cost-effective ratio to determine if a product can extend improvement and quality of life compared to alternative options. So nominally, this is in the early 2000s, this was set as £20,000 to £30,000 a year quality threshold to justify funding a treatment through the NHS. Not much money there. And then further to that, looking at patients receiving end-of-life care, but these are patients with metastatic disease, so their treatment time could be short. This was increased to a 50,000 threshold for those cohorts. And then further still in 2016, 100,000 for treatments of rare conditions. That's just not cancer, just rare conditions. But in all of these cases, commonly, these are assessing robust phase 3 data, and infrequently where phase 2 studies have demonstrated solid evidence, there's an association of biomarker to justify its use. So I give an example of a successful technology appraisal was looking at the cost effectiveness of pembrolizumab in microsatellite instability and mismatch repair deficiency tumors. And what you can see in the results at the bottom is that £130,000 required was the cost of pembrolizumab with an associated 3.88 QALYs. And then in the standard of care, it was 28,000 with 0.72 QALY. Now, when you look at the ICER, this was 32,000, and with discussion with the pharmaceutical company, reduced down in terms of cost to provide cost-effectiveness treatment and funded through the NHS. With this study, we're not going to get that, unfortunately. The data is immature, there's small numbers, the disease-free survival isn't a marker of overall survival, we don't have a clear prognostic biomarker as yet, and have we truly tested against the standard of care? There's no survival benefit. What is the QALY benefit? And the total cost of this treatment is approaching £90,000. And also, we need to be mindful of who we recruit into these studies. The recruitment should represent real-world practice. And we all struggle with this, and we need to ensure that these studies represent the patients we see every day. So the unanswered questions. With UPS, what is the standard of care? UPSs are not all the same. Can we pre-select suitable cases? Do we have the correct schedule? I think we do have the correct schedule for immunotherapy. Dedifferentiated liposarcoma, again, what is the standard of care? And can we really conclude on outcomes? We've got 6% in each arm, sorry, not 6 patients. And we need to still learn from the ongoing studies and the translational research related to that. We've been here before. Phase 2 to phase 3 was unsuccessful. So we have to use this information that we have, the clinical risk stratification, the translational research, to create a robust phase 3 trial design to try to ensure we are able to fund the patients for the right treatment. So, neoadjuvant immunotherapy should not be standard of care approach for patients with large, high-grade, primary localized extremity, trunk, soft tissue sarcomas. Back to you now.
Okay. Back to Dr. Bowie.
All right, so this is my finest work, by the way, using AI. But, you know, I want to tell a story about the sarcoma oncology specialty. So I had a resident in my clinic this week, and she was working with me, seeing my patients, prepping the notes. And after she was done prepping, she asked me, how come half the patients you see, I try to look it up in the guidelines, and either the tumor is not mentioned at all, or if it is mentioned, there's no real clear advice about what to do. And so I like to think of our specialty as kind of the Wild West oncology specialty, where we're this doctor trying to use evidence-based medicine to wrangle this sarcoma, but we are in a data desert for a large portion of what we do. And I think it's illustrated by a few things. So one, many subtypes are not even mentioned in the NCCN guidelines nor up to date. So we rely on case series, personal experience, or talking to colleagues. Even for something as basic as giving adjuvant chemotherapy, which is the basic kind of standard for a lot of different cancer types, there's no clear standard in sarcoma. That leads to different institutional provider preferences, and you can be treated differently depending on where you are and who you see. And I think this also leads, because it's a rare disease, it means trials with relatively small sample size and underpowered subgroups. So this could lead to drugs with marginal efficacy or unclear efficacy being FDA approved or on guidelines. So I think this is all something that we kind of deal with on a day-to-day basis as a sarcoma oncologist, is trying to make evidence-based good decisions on imperfect or incomplete data. And I think this does apply to SARC032 in some ways. I think, as was just mentioned, can we apply the trial results to all histologic subtypes, even with minuscule accrual to other arms? DDIF liposarcoma and Myxofibrosarcoma only had 4 to 6 patients in each arm. Is disease-free survival an adequate endpoint for adjuvant studies, or is the gold standard overall survival? I think in the US, we can use pembrolizumab in the metastatic setting because it is in the NCCN guidelines, so that could confound overall survival if you use it after the adjuvant setting. And then finally, what is the availability of the drug without FDA approval? It's in the NCCN guidelines for the metastatic setting, so we can use it, but it's not currently in the NCCN guidelines for adjuvant usage. And then what about worldwide? As was just discussed, there is cost-effectiveness analysis in other countries, so pembrolizumab is not available as standard of care, even in the metastatic setting for other countries. So can we truly say that this is a standard of care approach if we can't even use it standardly across the whole world? And even though we can use pembrolizumab in the US pretty readily for metastatic and adjuvant patient, at what cost do we give to society and to the patient itself? So the US has the most expensive healthcare in the world, with the per capita healthcare expenditure double that of the closest nation. And also, patients are burdened sometimes with medical debt. So for here on the right, you can see all adults, about 8% have some form of medical debt, while you get to worsening health status, which most cancer patients will probably be in the fair to poor category, have higher rates of medical debt. So I think this is something that we have to think about when we use this approach. So in terms of my final answer, I think based on everything that I've seen and heard so far, I probably would recommend neoadjuvant pembrolizumab for UPS and MFS at high risk. For liposarcoma, I'm less convinced because of small sample size and less efficacy in the metastatic setting. High risk I would define by the SARC032 trial criteria, more than 5 centimeters and grade 3. I probably wouldn't treat for grade 2 given the small subgroup analysis and also with the circulator data. I think chemotherapy is an option for patients with large tumors needing cytoreduction or patients with rapidly progressive tumors. And I think the future is probably a chemotherapy immunotherapy combination. So maybe it's time for a new trial and a new debate. All right, and that is my final presentation.
So obviously, I've convinced you to come over to my way of thinking now. So my thoughts, if I may, some fine-tuning. Yes, I agree, it's impressive in high-grade UPS as an alternative to doxyphos in selected cases. Yes, it may be a more tolerable strategy, and also further still, could we consider combination and complete immune checkpoint blockade? But remember not to decondition that patient. My surgical colleagues would be very unhappy if the patient was not fit for surgery. There's no change in practice in other subtypes. It won't pass NICE approval. And a suggestion, a phase 3 study, but a 3-arm study to try and really answer, can we do chemo or immunotherapy or radiotherapy and surgery alone? Then you've got all 3 arms and everyone's happy. Realistically, it's probably not going to happen. And also, we need to increase the number of patients with D-diff liposarcoma and pleomorphic liposarcoma into the cohorts because they deserve to be tested properly. The most important is the translational research and the output and looking at how we redefine these appropriate histological subtypes. And then also looking at, we haven't really discussed how many cycles of adjuvant immunotherapy. Now, could we consider reducing that? Because that could also impact on cost effectiveness, particularly if it's not truly beneficial in delivering up to 14 cycles in the adjuvant setting. So I got my colleagues to do some hard work for me. I'm very grateful to their opinions, and some of them are in the audience today. And sorry, there's lots of text there, but feel free to browse through. So speaking to the primary investigators of the study, David has highlighted in Canada, this will not approve funding and therefore not routinely used. Yvonne did highlight that since this study, there has been uptake in considering immunotherapy in patients, but also practice has changed a little in her institution in that more patients are receiving neoadjuvant chemo in other subtypes. MD Anderson, treatment is reimbursed, but not routinely used by all practitioners. In terms of, Ashley was describing, to test cytotoxic chemo, should we be using it with immunotherapy or should it be sequential? Uncertain regarding the efficacy of using as a combined approach. Herbert kindly also explained that reimbursement in Hong Kong is not feasible, but again, highlighted what I've described, what is a true standard of care, and ideally would like to consider it in selected cases. Alex has described also that we need longer follow-up, and I alluded to that earlier, and also in Italy you can't fund it, and also whether to test chemo-pembro to check, to really determine the advantage there. And Angela's working hard in Australia to try to attain funding from the government to help patients receive this treatment. And those patients they want to be suitable for the study, suitable for the treatment, are those in the inclusion criteria. So I had 3 for versus 3 against, but even in the 3 against, they'd recommend in selected cases if they could. Then I also asked Liz Connolly. Now, she's a relatively newly appointed medical oncology consultant, but has been in the sarcoma field for a while now. And she's described phase 3 study, yes, that would be feasible, uncertain regarding efficacy for dedifferentiated liposarcomas, and as like all of us, still trying to understand the great debate on chemotherapy. And I asked AI, crass AI, and they all said no. But what's really interesting, which is quite funny and sad, is that co-pilot said may make mistakes, and they made a blatant mistake that the trial demonstrated a 39% improvement in DFS, which isn't obviously the case. So, my final slide. What should be the next study? Because I don't think this is standard of care as yet. May we agree on what our standard of care should be and which subtype should we focus on for immunotherapy? And as please, 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 I realize that's a song by Sabrina Carpenter, so I'm just trying to show some commonality that I know about pop stars. You can incorporate the clinical risk stratification. Please incorporate risk stratification from the circulator, the translational results from all these studies into future studies so that we can truly understand the disease entities. We can deliver hyperfractionated radiotherapy, and it may be advantageous with immunotherapy. And does it really make sense to combine chemotherapy and immunotherapy? Yes, Nam highlighted this is in other tumors, but has it been tested with doxyphos? Is it going to reduce this immunotherapy benefit? So I will compromise and agree that consider, if I was able to offer it in selected grade 3 UPS patients, and also if we are able to use it, can we collect tissue and clinical data and collect this data prospective for real-world data analysis? So my final slide is a thanks to everybody. Sandra and Robin, I was just walking past you on a coffee at ESMO and then got invited to present here. And to everyone else for providing their thoughts and opinions. I'm very grateful and thank you.
Really outstanding presentations. I would love to open this up to the audience, but we're short on time, and we all appreciate that all of us in the room have agreed to disagree, and we could move on. That being said, I would like to can we put the prior poll results up one more time? And it would be great to see if anyone's perspective changed or remained the same afterwards. So for those that are not interested in this approach, it seems that their mind was not changed. For some, it seems that those that are interested for selected subtypes, there was a bit of a decrease in its use after the presentation. Well done. But then on the contrary, for others, it seems as though there seems to be a push towards using this approach when chemotherapy may not be a viable option. And those that said yes for all sarcoma subtypes, perhaps that's just a typo. Thanks so much to our presenters. This was lots of fun, and thanks for adding some humor. And again, we agree to disagree, and we move forward to the next session.